further along it gets, up in the age section, the worse it can get. Some of the things that cause it are like Cryptococcus uniformans and cytomegalovirus. Cytomegalovirus is everywhere. Chances are good, most of us in this room have it, but our immune systems are intact, so it's not bothering us. The problem we run into is when your immune system is compromised, you can suffer from it. You can also end up with peripheral neuropathy, so you're checking cognition, but you're also watching for their balance, for one. If you can't feel your feet, your balance is going to be compromised. Depression, again, is enormous. Risk of injury, absolutely. Let's pretend we don't have that one there. Who can tell me about a different nursing intervention that we could use for people with HIV? Spencer? It gives away a whole bunch of them right here. Name one.
Impaired comfort?
Okay. Anybody else come up with one? Nursing interventions.
Infection control.
Infection control, yeah, absolutely. How do we do that?
Universal precaution.
We're washing our hands a lot. We're making sure everybody that comes into contact is washing their hands. Put a sign on their door that says, do not go in here unless you talk to the nurse first. That way you get to talk to them before they go in. You can identify if they've got sniffles or a cold or some other problems. Anybody else? Nursing interventions or nursing diagnoses? Elena?
I guess if they're having like cognitive behavior, motor decline, just like making sure to keep them oriented.
Oriented, I like that, yeah.
And engaged.
Talk to them.
Yeah.
Make sure if there's a deficit there, you recognize it. You need to chart it and make sure everybody else on the care team is aware of it. If they're at increased risk of injury, would fall precautions be a good one?
Yeah.
We don't want them to have more problems than they already do, right? Yeah. Okay. Would they be at higher risk for shingles? Oh, absolutely. I forget, what causes shingles?
Chickenpox.
Chickenpox. Shingles usually shows up in older folks who are under stress. And like I said, I think I told you, they're supposed to be pretty painful. I got them when I was under stress, and it was an annoyance. I'm sure they're worse for other people. It's a really good example of it. What would a good nursing diagnosis be for this one? Kate? What should I go with?
Impaired skin integrity.
Impaired skin integrity, excellent. All right, let's come up with 10 nursing diagnosis and interventions. I actually have them on. How about ineffective airway clearance or altered breathing pattern? Since they've probably gotten this DJP, one of the most common infections that goes with AIDS. We're gonna manage their activity. Make sure that they get short of breath, that it's not gonna cause them additional problems. Fowlers or semi-fowlers, to make sure it's easier for them to breathe. Pulmonary hygiene, coughing and deep breathing. Anytime somebody's got pneumonia, I tell them, patient teaching, this is your job. You want to get better, deep breathing, cough. Cough up the gunk that is in your lungs. If you're not taking deep breaths, you're not getting the stuff out of the bases of your lungs. And it's the same way with somebody with PGAP. What's some goals that they can have? What's a goal for somebody who has ineffective airway clearance? Great.
Keep their SpO2 above a certain percent.
Good. What's a good percentage?
92?
92 is pretty good. How about 89?
Maybe if they have COPD.
Some people you see at 89, because 88 is usually the cutoff that says they're gonna need oxygen at home, right? Low 90s is good if they can get it, mid 90s even better, depends on the person. How about another one? About a center spirometer, and there's a goal set right on there. Set them a high goal. In fact, this is gonna be used for somebody that has AIDS or they're in the decompensation part. Give them a goal that they can reach. And then set it a little higher when they reach it. Makes them feel a little better about themselves. Impaired skin integrity. Woo-hoo. Frequent routine assessments of their skin because it's gonna change literally day to day. Sometimes over an hour. I forget, did we do the knuckle thing when we were talking about decubitus ulcer? No? I love this. This is good teaching. Okay. Take one finger and put it on your knuckle. Then take it away and look at it. It's white. There's no blood get into there. When the blood doesn't get there, it doesn't have the constituents that your body needs to keep that tissue healthy. So it doesn't take a huge amount of pressure on somebody's hip bone or sacral bone. In an hour or two, you can come up with a decubitus ulcer. So it's important to reinforce for people that are just bony. Every part of their body is going to be at risk for skin breakdown. So it's a constant battle to keep their skin intact. And feel free to use this mnemonic for your patients. Look at that. That means that tissue is going to die if it doesn't get some blood. So you've got to keep moving. What are some goals to keep their skin intact? Altered bowel elimination or diarrhea. Run into it a lot. What's one of the main things we worry about if somebody has ongoing diarrhea?
Food and electrolytes.
Food and electrolytes. Which electrolytes are going to be suffering?
Sodium.
Potassium, mainly, sodium, yeah. Avoid foods that act as bowel irritants. Some people really like these foods. My wife is one of them. She likes that spicy food. She has GERD. I'm like, darn, huh? You can't teach your family. I'm not sure what that's about. Raw fruits and vegetables. Why do those cause worse diarrhea?
Fiber.
It's fiber, yeah. Moves things faster. Small, frequent meals to help them improve their ability to absorb it. Medications, it depends on the patient, the doctor, and their situation. If they can't swallow, they have to do it IV. So if you need medication, you can do IV. The lab values absolutely for those electrolyte problems. What's a good bowl for somebody with altered bowel elimination? What's normal? Ask what the patient was on, whatever the patient was on. Everybody's different. Risk for infection. There's nothing infection. Recognize it before it shows up, or when it shows up as early as possible. Watch for those subtle signs. What's a subtle sign of an infection?
Like temperature, like if their temperature goes up?
Fever will, yeah. Even a small fever can be a huge problem for somebody that's AIDS, that has AIDS. Watch, tell the patient what they should be watching for. Activity intolerance. Such a cute picture.
That's
If
good
you only
advice.
have a certain amount of energy, make sure they're using it appropriately. How about recreation? You only have a little bit of energy. How are we going to help the person maintain a mental health status quo if all they can do is get up and walk to the bathroom once every couple hours? That's all the energy they have. What do you think? What can we do? Trevor.
Frequent rest periods, or
Frequent rest
have them
periods.
think
Okay.
about the activity before they do it, so they can try and, I don't know, be more efficient with doing it.
Yeah, more efficient, basically have things close by. Unfortunately, it's kind of important for them to get up and move around, but it's hard to do. Talk to other members of our healthcare team, your CNA especially, because they're the ones that usually have the most contact with. Altered thought processes. It can be difficult for them to focus, to concentrate. You can tell them something and they will completely go past. So reinforce, sometimes you need to write it down, make sure that they can read it, make sure they have their glasses. Structure for their schedule, to make sure that things are, become habitual for them. Talk to the family about a safe home environment. Imbalanced nutrition. This is a good option. Boost or Ensure, they've got a lot of different ones. What was it? I think it's Ensure. They have like 15 or 20 different varieties for different illnesses. Ensure is pretty neat. And I've tasted it. It's pretty good too. You guys ever taste Ensure? You wanna try it? You can buy it in the grocery store. You wanna know what some patients won't eat it, won't drink it. Because it gets nasty. Control nausea as much as you can, because it causes additional problems. You know, get on top of their nausea problems. And sometimes it takes more than one nausea medication at a time to do it. Acute and chronic pain. Kaposi sarcoma can be very uncomfortable. NSAIDs, opioids, position changes for them. Help them find a comfortable position. And pillows are huge. Make sure they have lots of pillows. Because if you are 6 feet tall and weigh 120 pounds, everything's gonna hurt. Anticipatory grieving, patient and their family. Is it okay for them to be sad? Pretty much expected. Can you tell them dumb jokes? Ask them up front. I've had patients. I ask them, so, you wanna hear a dumb joke? They said, no. Good. Most patients like it. Social isolation. This is pretty huge because of the, a lot of people with HIV or AIDS are treated like pariahs. It's not as bad as it used to be, it's getting better, but it's still a fact. Still a big part of your, taking care of your patient. Impaired home maintenance. Yeah. If they can't get up and move around and take care of themselves, they're not gonna be able to take care of the house. Other questions? Okay, let's do this. Come on, Deb, let's do it. Did you guys get a chance to watch this, or did you try and run into this message?
You just click on the top. Like, yeah.
Ah, okay. It's never as easy as it should be.
take a moment and look at this photo and really reflect on some of the things that come to mind. And what are some of those things, those words? Now, I'm going to ask you all to look at me. What words come to mind when you look at me? What separates that man up there from me? The man in that photo is named David Kirby, and it was taken in 1990 as he was dying from AIDS-related illness, and it was subsequently published in Life magazine. The only real thing separating me from Kirby is about 30 years of medical advancements in the way that we treat HIV and AIDS. So what I want to ask next is this. If we have made such exponential progress in combating HIV, why haven't our perceptions of those with the virus evolved alongside? Why does HIV elicit this reaction from us when it's so easily managed? When did the stigmatization even occur? And why hasn't it subsided? And these are not easy questions to answer. They're the congealing of so many different factors and ideas. Powerful images like this one of Kirby, these were the faces of the AIDS crisis in the 80s and 90s. And at the time, the crisis had a very obvious impact on an already stigmatized group of people, and that was gay men. So what the general straight public saw was this very awful thing happening to a group of people who were already on the fringes of society. The media at the time began to use the two almost interchangeably, gay and AIDS. And at the 1984 Republican National Convention, one of the speakers joked that gay stood for, "Got AIDS yet?" And that was the mindset of the time. But as we started to understand the virus more and how it was transmitted, we realized that that risk had increased its territory. The highly profiled case of Ryan White in 1985, he was a 13-year-old hemophiliac who had contracted HIV from a contaminated blood treatment. And this marked the most profound shift in America's perception of HIV. No longer was it restricted to these dark corners of society, to queers and drug users, but now it was affecting people that society deemed worthy of their empathy, to children. But that permeating fear and that perception, it still lingers. And I want to show of hands for these next few questions. How many of you in here were aware that with treatment, those with HIV not only fend off AIDS completely, but they live full and normal lives? Y'all are educated. How many of you were aware that with treatment, those with HIV can reach an undetectable status, and that makes them virtually uninfectious? Much less. How many of you were aware of the pre- and post-exposure treatments that are available that reduce the risk of transmission by over 90%? See, these are incredible advancements that we have made in fighting HIV, yet they have not managed to dent the perception that most Americans have of the virus and those living with it. And I don't want you to think I'm downplaying the danger of this virus, and I am not ignorant of the harrowing past of the AIDS epidemic. I am trying to convey that there is hope for those infected, and HIV is not the death sentence it was in the 80s. And now, you may ask, and I asked this question myself initially, where are the stories? Where are these people living with HIV? Why haven't they been vocal? How can I believe these successes or these statistics without seeing the successes? And this is actually a very easy question for me to answer. Fear, stigma, and shame. These keep those living with HIV in the closet, so to speak. Our sexual histories are as personal to us as our medical histories. And when you overlap the two, you can find yourself in a very sensitive space. The fear of how others perceive us when we're honest keeps us from doing many things in life. And this is the case for the HIV-positive population. To face social scrutiny and ridicule is the price that we pay for transparency. And why become a martyr when you can effectively pass as someone without HIV? After all, there are no physical indications you have the virus. There's no sign that you wear. There is safety in assimilation, and there is safety in invisibility. I'm here to throw back that veil and share my story. So, in the fall of 2014, I was a sophomore in college, and like most college students, I was sexually active, and I generally took precautions to minimize the risk that sex carries. Now, I say generally because I wasn't always safe. It only takes a single misstep before we're flat on the ground, and my misstep is pretty obvious. I had unprotected sex, and I didn't think much of it. Fast forward about 3 weeks, and it felt like I'd been trampled by a herd of wildebeest. The aches in my body were like nothing I had felt before or since. I'd get these bouts of fever and chill. I would reel with nausea, and it was difficult to walk. Being a biology student, I had some prior exposure to disease, and being a fairly informed gay man, I had read a bit on HIV. So to me, it clicked that this was seroconversion, or as it's sometimes called, acute HIV infection. And this is the body's reaction in producing antibodies to the HIV antigen. It's important to note that not everybody goes through this phase of sickness, but I was one of the lucky ones who did. And I was lucky as in there were these physical symptoms that let me know, hey, something is wrong. And it let me detect the virus pretty early. So just to clarify, just to hit the nail on the head, I got tested on campus. And they called me, or they said they would call me the next morning with the results. And they called me, but they asked me to come in and speak to the doctor on staff. And the reaction I received from her wasn't what I was expecting. She reassured me of what I already knew, that this wasn't a death sentence. And she even offered to put me in contact with her brother, who had been living with HIV since the early 90s.
Counseling.
I declined her offer, but I was deeply touched. I was expecting to be reprimanded. I was expecting pity and disappointment. And I was shown compassion and human warmth. And I'm forever grateful for that first exchange. So, obviously, for a few weeks, I was a physical mess. Emotionally, mentally, I was doing okay. I was taking it well. But my body was ravaged. And those close to me, they weren't oblivious. So, I sat my roommates down and I let them know I'd been diagnosed with HIV, that I was about to receive treatment, and I didn't want them to worry. And I remember the look on their faces. They were holding each other on the couch and they were crying, and I consoled them. I consoled them about my own bad news, but it was heartwarming to see that they cared. But from that night, I noticed a shift in the way that I was treated at home. My roommates wouldn't touch anything of mine, and they wouldn't eat anything I cooked. Now, in South Louisiana, we all know that you don't refuse food. And I'm a damn good cook, so don't think that passed me by. But from these first silent hints, their aversion got gradually more obvious and more offensive. I was asked to move my toothbrush from the bathroom. I was asked to not share towels. And I was even asked to wash my clothes on a hotter setting. This wasn't head lice, y'all. This wasn't scabies. This was HIV. It can be transmitted through blood, sexual fluids like semen or vaginal fluids, and breast milk. Since I wasn't sleeping with my roommates, I wasn't breastfeeding them, and we weren't reenacting Twilight, I was of no risk to them, and I made this aware to them, but still this discomfort, it continued until eventually I was asked to move out. And I was asked to move out because one of my roommates had shared my status with her parents. She shared my personal medical information to strangers. And now I'm doing that in a room full of 300 of y'all. But at the time, this was not something I was comfortable with. And they expressed their discomfort with their daughter living with me. So being gay, raised in a religious household, and living in the South, discrimination wasn't new to me. But this form was. And it was tremendously disappointing because it came from such an unlikely source. Not only were these college-educated people, not only were they other members of the LGBT community, but they were also my friends. So I moved out at the end of the semester, but it wasn't to appease them. It was out of respect for myself. I wasn't going to subject myself to people who were unwilling to remedy their ignorance, and I wasn't going to let something that was now a part of me ever be used as a tool against me. So I opted for transparency about my status, always being visible. And this is what I like to call being the everyday advocate. The point of this transparency, the point of this everyday advocacy was to dispel ignorance. And ignorance is a very scary word. We don't want to be seen as ignorant, and we definitely don't want to be called it. But ignorance is not synonymous with stupid. It's not the inability to learn, it's the state you're in before you learn. So when I saw someone coming from a place of ignorance, I saw an opportunity for them to learn. And hopefully, if I could spread some education, then I could mitigate situations for others like I had experienced with my roommates and save someone else down the line that humiliation. So the reactions I received haven't been all positive. Here in the South, we have a lot of stigma due to religious pressures, our lack of a comprehensive sex education, and our general conservative outlook on anything sexual. We view this as a gay disease. Globally, most new HIV infections occur between heterosexual partners. And here in the States, women, especially women of color, are at an increased risk. This is not a gay disease, it never has been. It's a disease we should all be concerned with. So initially, I felt limited. I wanted to expand my scope and reach beyond what was around me. So naturally, I turned to the dark underworld of online dating apps, to apps like Grindr. And for those of you who are unfamiliar, these are dating apps targeted towards gay men. You can upload a profile and a picture and it'll show you available guys within a radius. Y'all have probably heard of Tinder. Grindr has been around for a lot longer since it was much harder to meet your future gay husband at church or the grocery store, or whatever straight people did before they found out they could date on their phones. So on Grindr, if you liked what you saw or read, you could send someone a message, you can meet up, you can do other things. So on my profile, I obviously stated that I had HIV, I was undetectable, and I welcomed questions about my status. And I received a lot of questions and a lot of comments, both positive and negative. And I want to start with the negative, just to frame some of this ignorance that I've mentioned before. And most of these negative comments were passing remarks or assumptions. They would assume things about my sex life or my sex habits. They would assume I put myself or others at risk. But very often I would just be met with these passing ignorant remarks. In the gay community, it's common to hear the word clean when you're referring to someone who's HIV negative. Of course, the flip side to that is being unclean or dirty when you do have HIV. Now, I'm not sensitive and I'm only truly dirty after a day in the field, but this is damaging language. This is a community-driven stigma that keeps many gay men from disclosing their status, and it keeps those newly diagnosed from seeking support within their own community. And I find that truly distressing. But thankfully, the positive responses have been a lot more numerous, and they came from guys who were curious. And they were curious about the risks of transmission, or what exactly undetectable meant, or where they could get tested, or some guys would ask me about my experiences, and I could share my story with them. But most importantly, I would get approached by guys who were newly diagnosed with HIV, and they were scared, and they were alone, and they didn't know what step to take next. They didn't want to tell their family, they didn't want to tell their friends, and they felt damaged, and they felt dirty. And I did whatever I could to immediately calm them, and then I would put them in contact with Acadiana Cares, which is a wonderful resource we have in our community for those with HIV. And I put them in contact with people I knew personally so that they could not only have this safe space to feel human again, but so they could also have the resources they needed in affording their treatment. And this was by far the most humbling aspect of my transparency, that I could have some positive impact on those who were suffering like I did, that I could help those who were in the dark. Because I had been there, and it wasn't a good place to be. These guys came from all different backgrounds, and many of them weren't as informed as I had been, and they were coming to me from a place of fear. Some of these people I knew personally, or they knew of me, but many more, they were anonymous. There were these blank profiles who were too afraid to show their faces after what they had told me. And On the topic of transparency, I want to leave y'all with a few thoughts. I found that with whatever risk or gamble I took in putting my face out there, it was well worth any negative comment, any flack I received, because I felt I was able to make this real and this tangible impact. And it showed me that our efforts resound, that we can alter the lives that we encounter for the good, and they in turn can take that momentum and push it even further. And if any of you or anyone you know is dealing with HIV, or if you want to see what resources you have in your community, or just educate yourself more on the disease, here are some wonderful national sites that you can access, and you are more than welcome to find me after this talk and ask me anything you'd like. We've all heard the phrase, to see the forest through the trees. So I implore all of you here to really see the human through the disease. It's a very easy thing to see numbers and statistics and only see the perceived dangers. It's a much harder thing to see all the faces behind those numbers. So when you find yourself thinking those things, those words, what you might have thought looking at David Kirby, I ask you instead, think son, or think brother, think friend, and most importantly, think human. Seek education when faced with ignorance, and always be mindful, and always be compassionate. Thank you.
That's pretty well done. What do you think? Informative, not too wordy. Any questions? Comments? Myths? Urban legends? Stupid jokes? Okay. We can, actually, I'm gonna have you guys do it on your own. I'm gonna open up some scenarios in there. I want you to just kind of go through them and get a feel for them. What you would do if you want to meet as a group and do it in groups, that would be okay. Otherwise, that's all there is. I'll see 5 of you in my office in a little bit.
What lecture are we going
I think tomorrow is Neuro.
So we're not covering cancer.
Yeah.
We're not covering cancer.
We are covering cancer.
Are we?
Is it tomorrow?
Yes.
I'll have to double check.
Well, I'm just talking about what should be prepared for tomorrow's quiz, like what do we need to study for?
Good point.
Yeah, so.
Is there gonna be a quiz tomorrow? Probably.
There is no cancer modules open.
One more.
There is no cancer module open on Canvas.
Sorry, you gotta keep waiting for me.
I thought no, we were gonna see. Sorry.
You turned the projector off, though.
Yeah. Sorry.
I'm done.
Delay.